Welcome to our meeting of the Bobby Jones Chiari Surgical Foundation Charleston chapter. It's good to see everyone here. Just to let you know, we have a walk coming up September 28th. So I hope to see everybody there, and I hope everybody will get up their team and help support it. It's always fun. It's a fun event. Our next meeting we're working on is probably, the target is November 7th, so I have to get a speaker, and we'll see if we can get it scheduled for November 7th. And once a month we have online support groups. So if you ever want to join in a virtual support group, please check on the Bobby Jones CSF website, and you can see when it is. It's usually the third Tuesday night of the month. So we have an interesting speaker tonight, and we have we're going to talk about research in relationship to nursing care, and we have someone who has been on both sides of nursing, as a patient and as a nurse, and we're going to hear a little bit about her story, and then we'll be able to see why we need to have a lot of research and everything. I hear a lot of horror stories, you know, some about nurses who were angels and some where there's such a deficit in knowledge, and they come across as not caring, but it's because they just don't know and they don't understand. So let's hear one person's experience. This is Gretchen, and I'm not going to pronounce her last name.
Yeah, it's crazy. Yeah. I'm not like a super big public speaker, so just bear with me. So I'm Gretchen Jongekryg. I'm 26. I have been a nurse for 2 years now. I kind of knew I had EDS probably about 4 years ago, but I only officially got diagnosed a year ago. I have nursing experience working my whole career. I've been at MUSC here. So I worked on 9 West, the neuro med-surg unit, taking care of a lot of neurosurgery, stroke, and epilepsy patients. And I have recently, kind of 8 months ago, transitioned into working in the PACU recovery area, taking care of patients out of surgery. So you might see me like, hey, it's time to wake up. Might be me. So as you can imagine, nursing while having hypermobile EDS has come with a lot of different challenges. I actually didn't get diagnosed with hypermobile EDS until a year into my nursing career, while I was taking care of hypermobile EDS patients. So the diagnosis honestly was super scary. I think MUSC specifically takes care of a lot of complex patients with EDS. I know a lot of people come from all over. I've had patients from Australia come to MUSC for care. So if that doesn't speak to the complexity of the patients that we take care of, I don't know what does. But so a lot of days were just really difficult. It was very physically taxing. I was taking care of a lot of stroke patients that are considered a lot of times total care. I would need to move them up in bed a lot of physically demanding things in that job. So it taught me a lot of things about body mechanics and the importance of compression socks and all the little things like, you know, stability devices for my posture and all these things I would wear at work just to get through the day so that I wasn't in tears by the end. I know a lot of us would consider hypermobile EDS a invisible, disability. A lot of people would look at me and have no clue that I had hypermobile EDS. So that, is a blessing and a curse because, nobody thinks that you're living in chronic pain when you're living in chronic pain. And I do think, though, that it gave me a whole different side of empathy towards my patients because I'm taking care of patients with the same disease as me. And there's a massive lack of empathy, I think, in the healthcare field. So being able to relate to my patients, having that empathy, the knowledge that a lot of healthcare professionals didn't, was a really big blessing to me and to my patients. I think a lot of us come into healthcare with a lot of different experiences with healthcare providers, a lot of frustration, a lot of misdiagnoses. Honestly, probably a lot of us have had a ton of different things that they tell you that you have all the way up until you finally get your diagnosis and it all makes sense. And so I think it comes with a lot of frustration, a lot of mistrust of the medical system, if you will, and a really big lack of continuity of care as well, because nobody really fully understands the whole disease process. So I've seen it from that whole patient perspective, as being the patient that's been thrown from patient, doctor to doctor to doctor, being very frustrated. But then on the other side of being in patient care, I have seen the frustrations providing care, because, like I've said a million times, there's such a lack of knowledge. And I think a lot of people, specifically from my experience, a lot of people treat EDS as a musculoskeletal disease and that's it, and not a connective tissue disease, with the GI, skin, all the other complexities that come with the disease. So that's really frustrating when I'm trying to advocate for my patients. And I just think that's where EDS patients in healthcare facilities have gotten kind of a reputation of being difficult. I think that it's just a massive lack of understanding and empathy from the healthcare side, which is frustrating. And it was a lot to see every day at work, like being on both sides of it. So then I transitioned to working where I work now. It's a lot easier on my body and a lot less stressful mentally for me. But I just think that's where kind of a lot of the frustration goes. And it really brings up the importance of research, education. I think that I couldn't believe how many nurses who were working on the neuro med surg floor had no idea what EDS actually was and how it affects all the different body systems, because they really don't teach it in nursing school. I didn't even know what it was until I came really to MUSC. Even though they were telling me I had this thing, I was like, oh, weird, like rare disease. Tell me something I don't know. I've just been thrown to doctor, and nobody knows, and it felt like they were brushing me off. But then actually really learning about it and experiencing it for myself, it was just very, very different, but scary. So yeah, I don't know. I guess I have a little bit of encouragement that I just want to say. It's the rare disease motto. It's alone we are rare, but together we are strong. And I think that just speaks to the testament of this group and just patients that I've got to talk to. I actually had no idea what kind of resources I had as a patient with EDS in Charleston until my patients told me. So I just think it was super cool to have the support in the community that we have. Yeah. So thank you for listening to me, and you can ask me anything after probably, but yeah, that's all I have. Thank you guys.
Great job, Gretchen. Thank you very much. Yeah, I'm sure it has to be really, really frustrating when you're working with other nurses and they don't know anything about it. Do they listen to you when you try to teach them about it?
Yes and no. Honestly, I never really told a lot of people that I had hypermobile EDS because of the reputation that you have in the hospital. Which is sad because there's such a. I work with one other girl who has hypermobile EDS, and there are like 5 of us that know, and that's it. And so I tell my patients, but and the doctors know, because the doctors there are my doctors as well. Yeah. So it gives me like up in communicating to the doctors, but the nurses just don't like to hear it. Yeah. I think a lot of it comes with pain control. That's like a really big thing. Yeah. Which is frustrating as a patient. But it's also frustrating as a healthcare provider, especially a nurse. Like, I can't give medication that they don't order. But also, even if, let's say, the pain medication isn't working, it doesn't mean it's not your breathing or whatever, because they can only do so much.
Right.
So it's trying to like bridge that the
Yeah.
knowledge gap to your patients, but also the empathy from the healthcare providers. It's kind of weird.
Yeah.
It's a weird position to be in.
Yeah.
So,
Well, I know any of the patients on 9 West are very blessed to have you as their nurse. I'm sure they feel much better and they have a much better experience because you're taking care of them. So thank you for what you do.
Hey, thanks everyone. I think everyone knows me. I'm Kaitlyn Esposito, work for Bobby Jones CSF. I'm going to run through this relatively quickly so we don't get too bogged down. But I'm going to zoom in because it's like impossible to read. So, okay, so quick background. I think I talked about this last time a little bit. I'm going to talk a little bit today about the Chiari Surgical Success Scale. Really what the background of why we're doing this is there really isn't great medical literature on Chiari, syringomyelia, and the related disorders and their treatment. Right now, all you can really do is get neurosurgery, which may or may not help. None of that is helpful to people. So what we wanted to do was to produce a product that, like a tangible item that doctors and patients can use to have that surgical consultation. So the Chiari Surgical Success Scale is going to be that. What we're really doing is at baseline, we're collecting a bunch of imaging measurements, actual images that we're going to use as well, clinical information, symptoms, and PROs, so patient-reported measures. So I'll actually get to what they are in a second, but we're going to collect all that at baseline, and then at the end, we're going to see who did well with surgery. And what we're trying to do is basically our primary aim here. And what we're going to do is develop and internally validate, so make it reliable, a reliable scale, the CSSS, which is going to be able to predict who, when they walk in on day one, if they look like patient A who has this constellation of symptoms and images, are they 80% likely to do better after surgery, or are they someone who maybe falls into a different category, maybe 10% likely? And then from there, the neurosurgeon will be able to say, you know, I don't think you're going to do well with surgery, so why don't we try something else like physical therapy or anything else that can help with your symptoms, whatever they might be. So that's what we're developing, and it'll be useful on day one, the second it's available. We have some secondary aims as well. So the outcome measures that we're using are the PROMIS and the MIDAS. So we're going to look at like pain, fatigue, headache, disability, which is a big problem in a lot of patients. And the PROMIS is really good because it looks at your whole quality of life, including depression and anxiety, stuff like that. We're also going to look at complications and if there are any changes in those radiographic measures, which we know is a big deal for a lot of patients because they come in with a finding on an imaging and it doesn't necessarily mean that they have one thing or another, and it's very confusing. So we're going to collect all of that and try to look back and do our analysis that way. So quickly to talk about our methods, I won't get too deep into this, but all the patients that are coming into the clinic at each of these participating sites are being screened. So if you're coming in because you may have a Chiari that's going to have some kind of surgery associated, maybe you are being screened in this study. So it's going to be a lot of people. We're purposefully inclusive because we want to make sure we collect as many different people as possible. This is a very variable population. We want to make sure we're including everyone. Historically, most of the data sets have only included patients who have Chiari and syringomyelia or just syringomyelia. And that's it's a smaller subset of this population when we know that there are patients who have EDS, who have other things, and they're kind of being excluded from the medical literature. So we want to make sure that we include them. One caveat I will say is that we're only including 5 years and up because of the patient-reported measures that we're using. They're validated in 5 and up. I want to call out the exclusion criteria really quickly. These are patients that would be ineligible. We're not including CM1 types, but we are very specifically defining them as Chiari 2, 3, and 4. because they're different pathologies, they're not treated the same way, they fall victim to the whole nomenclature issue where they just happen to be discovered by the same guy a couple hundred years ago, and so it has the same name, but it's different. But we are very specifically including Chiari 0, Chiari 1.5, Chiari 0.5, and anything else they've come up in between and that I haven't found yet, but they're not being excluded from the study. We want to make sure we know what happens to those people as well. Scroll over here. This is so annoying. Okay. Okay, so we're collecting all this information, like I said, at baseline, it's all that imaging, clinical information, about 0 to 90 days after surgery. So once they're eligible, we'll start collecting all that. Our immediate post-op, so everything that happened in the operating room that doesn't necessarily end up like knowledgeable to you, or it's just stuck in the OR notes, we're collecting that within 7 days of that surgery to kind of make sure they don't forget what they did in the OR, but frankly, most of the surgeons that are involved have kind of done it the day of, and it's not been an issue. There are 2 follow-up windows. One is optional because it's not necessarily part of everyone's standard of care to see someone about 3-ish months out of surgery, but we do have that as an option. So 2 to 5 months after the surgery date, we're going to collect a bunch of stuff about complications, imaging, symptoms again, and the PROs. And then that final post-op is mandatory. So about a year out of surgery, most surgeons are going to want to see how you're doing and see if they need to do anything else to kind of help resolve symptoms. So that's 10 to 18 months after surgery, which is a big window to make sure we get everybody. And we're going to collect everything, including the primary outcome questionnaire, which is going to be used to develop that CSSS scale that we intend to use in clinics, hopefully immediately after, if it's well validated. I will mention this is a multi-center study, and most of these kind of projects have been at single institutions or 1 or 2. And I'll get to how many in a second. One other thing really quickly, sorry, there's so much stuff. If there is a reoperation, we're going to collect information at that time point too, because we think that's important, particularly in patients who have EDS, to make sure that if, for example, you decompress and then you make someone unstable, we want to make sure we know who those people were at the baseline and kind of be able to look back. So the study is actively enrolling. Right now, 1,200 patients have already been screened. Of those, 232 were eligible, and a surprising 203 have actually enrolled. So people are really interested in making sure that this study goes through. I'm really grateful for it. Only 40 participants have completed the study, so I can't draw any conclusions and I can't show you anything fun. But I guess I will say that 88% of everyone eligible has been enrolling, so that's really good, and only 2 sites are enrolling below 82%, so that's amazing, and there are a lot of patients that really want to see this go through. Okay, so these are the sites. There are 18 right now participating sites, and the way we structured this was the Chiari Clinical Research Consortium. So this is just a group of interested patient advocates and surgeons, investigators who really just want to make things better for patients, because right now there's really not a lot that they can go on based on the medical literature. And one thing I'll point out is that this study is unfunded, so all of these sites that are listed here are doing this for free, basically. They are devoting their staff and their time and their brains, I guess, to make sure that this goes through and we can get something that can be used in the clinic immediately. This is the first project in a long pipeline of projects that we intend to do with the CCRC. This is just the first one that we want to be able to launch and make sure that it's good, the data integrity is clean, and it's large, multi-center, just good stuff. So everything else is like underway, and I'm very excited for how it's going to go. I'm glad that we convinced them to include patients with hypermobile EDS and different conditions like that. We're collecting information on whether or not they got fusions and where and all that stuff. So all of this is going to be done It's about a 2-year study by the time a patient's enrolled. Sorry, no, that's not true. It's 2 years of enrollment with at least 1 year of follow-up, really 18 months. So about 3 years for each site at least. So this is a long haul, but we're on our way. And I guess I'll just end with this middle piece because it's the crux of the whole poster here. So the CSSS is the first project of the CCRC. 18 sites are involved, and that number is going up every month, it feels like. We're becoming involved, and over 1,200 participants have already been screened. The project is going to develop a practical tool that will improve neurosurgical care immediately and improve patient outcomes. And the project is exemplary of what trust and true academic partnership with patient advocacy organizations is able to achieve, because this is really done because there's like mutual respect between us and all of the sites that have already joined up, which are amazing. So I could talk about this all day, and I don't want to, but if you have any questions, please just let me know, and I'm happy to kind of answer them as we go. Okay. Oh, I don't know how to make it go away though. Thank you.
Thank you, Kaitlyn. And I can tell you, as a former nurse research coordinator, when you take part in a study, you get better care. You know, all these questionnaires that you're filling out, you go to see the doctor and they might ask a few things, look at you. You might not realize what is important to report, but they look at all these questionnaires, you fill out all these questionnaires, and there might be some things that are significant that would have been missed, but as a result of being part in this study, it's not going to be missed because they really dig in and learn a lot about you and what your experience is. So, you know, some patients might say, oh, I don't want to be a guinea pig. You are not a guinea pig. You're advocating. You're doing better for yourself. You're going to make a change in the future for other people. So I encourage anybody, whoever has an opportunity to take part in a research study, please do it. I think it'll be very important for you and for the future. So now to our speaker. So thank you, Kaitlyn. And I also think it really speaks a lot for the Bobby Jones CSF that all these sites have so much respect for them that they're willing to take part in this research without any funds going in their direction. And that also speaks a lot for the dedication of the medical people who really want to see things are going to change and they'll be able to take better care of you. So I know it often gets really frustrating and you think, you know, it's no better than it was 10 years ago. I can assure you there are a lot of people very dedicated and going way beyond to really make a change and see that the future will be better for all of the patients. So, and one of those people is our speaker tonight, Michelle Nichols. Michelle was very gracious to cut short her bio that would have been like 3 pages long. I was really impressed when I read her bio. She is quite dedicated, quite knowledgeable, quite accomplished, and we're lucky to have her here. But what we do have is Dr. Michelle Nichols is an associate professor at the Medical University of South Carolina College of Nursing. Her research focuses on multi-morbid chronic diseases, and she's an expert and methodologist in both qualitative and mixed methodological designs, using a community-engaged research approach among under-resourced and underrepresented populations globally. So we're honored to have you here tonight, Michelle.
Thank you. And it is a pleasure to be here. Let me just pull up these slides. Okay, perfect. Before I get started, I just want to say thank you, Gretchen, for not only sharing your story, but being vulnerable as well. Many of the things that you shared, I'm going to touch upon tonight, but I know it's not easy to be out there, expose yourself, and just be vulnerable, and I just want to thank you for doing that. So I am grateful for that. So tonight I'm going to talk about addressing the complexities of hypermobile Ehlers-Danlos syndrome care using community-engaged research. So community-engaged research is very different from a lot of other types of research. So I'm going to share my experience in doing community-engaged research, and I just want to put out there that I don't have any conflicts of interest or anything to disclose. So a little bit about me. I am a registered nurse. I have worked bedside, outpatient, you name it, I've done it. And Gretchen said what her age was. I'm not going to say, I've been a nurse longer than she's been alive, so I'll just leave it at that. And I was diagnosed with hEDS about the age that she is now. So I was diagnosed a long time ago, before there were pretty much any resources available. So as you know, I am an associate professor. I do have a PhD, and many of you may not have met nurse scientists, because only less than 1% actually of all nurses globally get a PhD. And even out of those, even fewer conduct research, because it's not easy and it's not inherently what nurses do. So I'm a little bit of an anomaly, not in academia, but in general as a nurse. My work does focus in global health. A lot of my work is in low and middle income countries, and predominantly is in sub-Saharan Africa. I have focused for many years on multi-morbidity. I like it when it's messy. I like it when there's multiple factors involved and we're not looking at a single disease state. And I work on those non-communicable chronic diseases. So many things like stroke, diabetes, issues like hypertension, obesity, anything of that nature. And so that's where the bulk of my research lies. I do disease prevention and treatment strategies, especially self-management. And then in Africa, I'm also involved in genetic, genomic, and biobanking research for stroke in order to address precision health. I have been begging for years to be able to advance and expand into the EDS research world. It was only in the last year that my department has given the green light to be able to move forward with it. So I am thrilled that I'm finally able to start doing research in this area and put together some of the pieces that I'm passionate about, and also be able to do this work. One of my hats that I wear here is that I am the Director of Community Engaged Research for our program through Sector, which is the South Carolina Clinical and Translational Research Institute. That goes statewide here in South Carolina, and it's funded by the National Institutes of Health. So one of the things that I focus on in my work is training academic and clinical scientists, as well as community members, on how to do research together and how to bridge those gaps. So that's part of what I'm going to be sharing today. And most importantly, probably the most important reason why I'm here is I'm also a patient. And I am fully committed. I agree that not enough has been done, but I will say I have a lot of hope for the future and where things are going. And in addition to a couple people who are in the room, I was just recently at the Global Learning Conference for EDS, and it was the first time in my life that I can say I honestly felt that it was okay to be me and not be judged. So some of the things that you were talking about, Gretchen, it was just okay for me to be who I am and not have to hide. So I think we're getting there. So I want for a moment for you all, and for some of you this won't be that hard, but to imagine, Gretchen shared some ideas, but think about it if you were a patient going to see your provider, you're out in the waiting room, you get called in by the nurse, they sit you down in the chair, They start to check your vital signs. Then they ask you what they always ask. Are you having any pain? And you just chuckle because you're like, what are you even asking? Of course I have pain. I have pain every day of my life. Are you talking about pain in general? Are you talking about a particular body part? Do you want a collective whole? What do you want? What are you asking? And then you tell them, yes, I have pain. Yes, I'm in pain. And then you even ask for that clarification. And you get these side eyes, or somebody's rolling their eyes like, what do you mean you have pain every day? You don't look like you're in pain. They think that maybe you are drug seeking, you're being a hypochondriac, and you don't even know how to answer their questions. Imagine also a scenario where you may be invited to go out with folks. Maybe it's coworkers, friends, family, and you're invited to go out and you have to decline because you are so tired, the fatigue is so overwhelming, you feel like your body has just slammed against a brick wall and you just have nothing more to give because you've had to push through so hard. Also imagine what it would be like to be wearing splints, collars, supportive or assistive devices to be mobile, and then a few hours later or the next day you don't have them. And people are questioning whether you're attention seeking, whether you're just a hypochondriac. These are some very simple examples, but they are very real and everyday experiences for people with EDS. And it's some of the reasons why we're not comfortable necessarily being vulnerable. I will say in my own experience, it's only been the last year that the team I work with was even aware that I had EDS, because I was not comfortable disclosing that because I had seen how other people were treated. I drive to work with all the splints on, everything on, and I take it off in the car and I hobble in to campus because I was afraid of how I would be judged. So those are things that need to change, and I think it's very important for us to collectively look at how comfortable we are and how we judge people and have empathy as well. So when we think about hypermobile EDS, there are so many complexities and symptoms as well as comorbidities. And the Norris Lab has created this figure that you see here, and many of you have likely seen it already. But what we do know is that this affects the entire body. Their multi-morbidities are so common with this population. So it's not like there's one problem and only one problem people are dealing with. The other challenge is not all of us have exactly the same problems. So it makes it hard for people to understand. There are so many symptoms that affect everyday life, whether you can be engaged in those activities, what your quality of life is like. And what we do know from the literature, and this number can vary, and we've even seen it much higher, but over 90% have chronic pain, which we're looking at as being greater than or equal to 4 hours a day for at least a 3-month period. Many of the people with EDS have had it for years. Some of this data that was recently collected by the Norris Lab even shows as high as 98%. So this is a very flexible number as far as what you see in the literature, but what it essentially tells us is it's widespread. Over 3/4 of the population has ambulatory limitations, and that's because of the musculoskeletal laxicity. There's also fatigue. I mentioned feeling like the body is hitting a brick wall. You might be sharing the symptoms of fatigue with folks and they're just like, oh yeah, I'm tired too. I'm like, no, you don't get it. This is not tired. This is your body will not let you continue. And many people, you don't see that because they're just going to push through until they collapse. There's also all the subluxations and dislocations that occur. And that can be a daily basis for people. mast cell activation syndrome, the POTS that's also listed here, GI problems, anxiety, depression, and these are just skimming the surface of what people experience. So this makes it very hard for anybody to even figure out what's going on with people as well as how to help or even understand. If we look at overall, when people have multiple comorbidities or multiple chronic conditions, recent data from the Centers for Disease Control and Prevention say about 130 million people, so 129, have at least one chronic disease. We also know that chronic diseases are related to about 3/4 of the deaths in the world globally. In the US, recent data are that 42% of adults have 2 or more chronic diseases. And then about 12% have 5 or more. But a recent survey that was done back in 2023 with a little over 500 individuals with hEDS showed that those individuals had on average 10.5 chronic diseases. And the recent data that I've referred to from the Norris lab shows about 11, average of 11 chronic diseases, and some go as high as 14, so some reports. So you can see how this compares to the general population. hEDS population is affected, has so many more chronic conditions that they're dealing with on a daily basis. So why do most clinical team members not understand? Well, first of all, as Gretchen alluded to, people aren't even trained in this. We also have the structure of our current healthcare system. This condition is very complex and it's variable. So not only does each individual, as we mentioned, have different symptom presentations, we also will have variation in your day. So it may be, like I said, you're wearing those assistive devices or supportive devices. Maybe you're having pain right now, but later you're not, or vice versa. All of these extra complexities and comorbidities make it even more difficult. And patients can often look okay. Just like the example I said of when the nurse is checking the vital signs and like, you look fine. Or that people, you show up to work the next day, but you canceled on everybody the evening before. They're like, you look fine, you don't look like you're sick. So that makes it even tougher for people to believe what's being said. We also have that diagnostic odyssey that we've referred to. It can take decades to get diagnosed, and that's a problem. So people are not getting diagnosed, which then in turn means they're not getting the treatment they need or appropriate treatment. And then there's so many more reasons why. So if we think about our current health system of care, it is impossible to even figure out. And I am a nurse and a scientist. I work at an academic medical university, and I have trouble finding which provider to go see. I can honestly tell you myself, I've had 5 of my own providers, because I have multiple conditions as well. 5 of my providers have left in the last year. That means starting all over again with new providers. Nobody has time to sit there and listen to my story or read through the volumes of medical history. So the structure that we have right now is really not set up to work for this population. When we think about traditional clinical visits as well, our healthcare system is set up for specialized care. So it's very disease or body system focused. So you might see someone for your GI problems. You might see another person for derm issues. You might see somebody for your mobility. Maybe you fractured your bones because of, your inability to ambulate safely. You're going to see a different person there. You might see a neurologist. The list goes on and on. And so that means there's no one looking at the whole person or all of the factors that are going in. Also, providers don't have time. You're lucky if a provider can spend 15 minutes. They come in, it may be even less in some clinical environments, come in, wash their hands, introduce themselves, say hello, listen to what you have to say, what your chief concern is or what your chief concerns are for that day, and then they've got to do the assessment, document everything, come up with a plan of care, and move on to the next patient. And so they don't have time to sit there and listen. If you can get a provider who can open up their schedule and block that hour to sit down and talk to you and hear what your concerns are, it's a rarity. There's also a backlog of just trying to get an appointment. Many people have years-long waiting lists, or there aren't providers available in the area who specialize in it. And then we also have just the lack of coordinated care. So those are all factors that go into play. I was asked to speak specifically to nursing education and what's going on. So this picture just essentially sums it up. If you look at what's on that chalkboard, it just goes on and on and on. So when it comes to connective tissue disease training or education that nurses receive, they learn about connective tissue disease in the anatomy and physiology courses they take. That's it. They do not get disease-specific education when it comes to the clinical courses. So when you think about the nurses aren't having empathy, they're not understanding the need for additional advocacy, they haven't been taught this. So it's not that people don't care. Nurses actually are a very caring group as a whole. You'll have your occasional, bad apple there. But as a whole, nurses go into the profession because they really do care and want to make a difference. But if they don't know what to ask. They don't know how to intervene. So some of the educational factors that are in consideration is that undergraduate nursing programs as a whole prepare for generalists in nature. So what that means is you're looking for the nurse to be able to go out, take a medical surgical position, or potentially start on a hospital unit as a beginner. They're a novice. You will then, as a new nurse, gain experience with on-the-job training or additional subsequent programs. But they're not expecting you to be an expert out of the gate, which you do see in other clinical disciplines. Also, because of the tremendous nursing shortages that exist, programs have had to switch to accelerated programs. And so what that can mean is that the nursing program can be as short, for a registered nurse, as short now as 18 months. That is fast. They don't have time to cover it. They're just throwing information out there, giving them what they need so they can pass the licensing board exam and be safe with basic patient care. When you do look at the connective tissue, like I said, it's only covered in the anatomy and physiology. And then when we get to the musculoskeletal conditions, it's only the most common. Same thing when it's talking about the dermatology or any other of the associated conditions. Only those they are most likely to see. This is not even on the examination questions. This same thing is quite similar in advanced practice training programs for graduate education, graduate training like nurse practitioner programs, physician assistant, as well as medical school training. There is very little information provided. There's a push now to enhance that, but even as we know, it very recently here at MUSC, the connective tissue disease training that the medical students were receiving was one slide with 3 bullet items on it. And I know that Dr. Norris shared that previously, but that is what it used to be. So there's a huge push here to change that and increase understanding and education. So what do? We really need to better understand lived experiences of persons with Ehlers-Danlos. We need to increase awareness, widespread, within the medical community, as well as the general public. Policymakers also need to know, otherwise the system's not going to change. This all includes expanding the training for all clinical health professions. We need to secure funding for research at all levels, basic science all the way up through translational research. We need to actually conduct clinical research studies with EDS. We absolutely have to reduce the time to diagnosis. It's not acceptable that people are waiting decades to get diagnosed. We have to have better treatment options and care delivery processes, and we really, in my opinion, need to have a holistic approach, looking at the entire person if we're going to adequately meet the needs of this population. So one way that I strongly advocate that we can look at this is through community-based participatory research. I used to focus only on inpatient clinical research years ago. And it was about 12 years ago that I really started to question what's happening when people leave the clinical trials. Why is everything falling apart? And so it sparked my interest in digging a little deeper and seeing how people actually live. So you can see here a definition of what community-based participatory research, or you might hear me use community-engaged research. But it is a collaborative process where we really are looking at equitable shared partnership in addressing health priorities to the population of interest. And so we're really looking to influence change and make a difference by hearing from the people who are most affected by a condition. This is a shift in what we traditionally think of from clinical research model, but it gets down to the essence of respecting the input of others. And I use this often when I'm training folks, and we were actually talking, some of us were talking about PCORI funded, which is patient-centered outcome research initiative. We were talking about that earlier, and this actually came up in one of our PCORI groups that had patients, stroke survivors, and their care partners. And they were even saying, there should not be anything that's occurring that has to do with me and my condition if I'm not part of the conversation. So I think that's really important for us to keep in mind. I've actually had a neurologist who was part of the stroke research, who said he had never met a stroke patient. And so he was doing bench research and had honestly said he had never done that. So part of our engagement process was to make that happen. So he could learn what it was like to have that experience and understand it from that point of view. So when we think of a traditional research model, we have the researchers essentially, whether it's bench scientists, basic scientists, or clinical scientists, they are determining, based on their knowledge and their expertise, as well as what's already been conducted, what needs to be done, what's important, what people have to do, what we need to focus on. And then they disseminate that information out to communities. The CBPR model puts everybody on the same playing field. So it's working together to make these things happen. I don't know about you all, but when I see a provider, they may tell me, okay, Michelle, you need to do whatever this is. I might not be doing that. Even though I know, I trust them, I believe them, I know it's important, but if they're not considering my life and how I live my life, all the things that are going into play, they're not really understanding whether or not I can do that. I might then be labeled as non-compliant, when in fact, it's not that I'm not compliant, you just haven't come up with a realistic plan. And so this also gets into determining, when it comes to research, what's most important to the people that we're trying to work with and help. So this has an image of a community-engaged research continuum. Often when researchers want to do community research, they will reach out to the community. They will try to find individuals who will help them recruit people for the research studies. And then they leave after they've collected their data, and they go back to their labs or their clinics. So there's essentially no involvement. As we progress along the continuum, the community might have some input. So maybe they're involved a little bit, begin to get a partnership. It isn't until we get all the way on the other end where we have community members who are trained in research, who are going in as investigators on our grants. They are also owning data. They are helping drive the research process that we actually get that true community engaged research. And that can happen, but to do so takes a lot of time and effort. There's a lot of mistrust that occurs, especially in the medical community. And if you're looking at certain demographics or geographic populations, there's even more mistrust. So it's building those relationships. It's navigating how are we going to address the obstacles that occur or conflicts that we may have. And then respecting what each group or individual brings to the table. And then sharing the challenges that may happen. So we've openly had conversations with our community members and partners to say, okay, the grant's going to end at a certain time. Just because you're not seeing us as frequently doesn't mean we're not still here. We're completely committed. And having those conversations up front, letting them know how long it takes to get a grant funded, and that we will likely get feedback and have to resubmit. So having that transparency and including them in all of the ownership of the research is important. So why do we want to consider using a community-based approach? Often the health interventions are too narrowly focused. Like I said, they're not necessarily considering everything that goes into an individual's life. They also may not consider some of the social determinants of health or those extra factors that may affect health disparities. That's true in our own population that we're here talking about tonight. They aren't necessarily tailored to the individual concerns, and that is a key component. And it might not also, the way we're conducting research may not respect the values, culture, and priorities of these particular groups. And the last bullet I have here on the top part, this is probably one of the most important things, is that it takes way too long to have information be adopted into practice. Here I've got a reference here where it says on average it can take 17 years. And even then, only about 1 in 5 studies that's conducted actually ever makes it into practice. So one way we can expedite that and shorten that gap is by including the people in the studies themselves. A key factor, and this can be hard for researchers, especially with highly credentialed, successful investigators, is to respect the community members as experts in their condition and in their own lives. That means checking the egos at the door and being humble and listening to what they have to say. So it can be quite a shift. It also enables equitable, respectful partnerships, and we really are focused in this approach on empowering community members. So there's a lot of bi-directional learning. The community members will share their expertise and their lived experience with the academic and clinical investigators, and the academic and clinical investigators may provide the community members with skills that they can take forward in their own daily lives. So how do we go about doing this? One key thing that we can do with very little effort is to convene community advisory boards. So even this group here can be considered a community advisory board or could convene a community advisory board. That board can then go and share expertise or input and say what's really important. They can also have connections that open up doors to other possibilities, or may give very valuable information to the researchers. The key here is really recognizing and respecting the expertise of persons with the lived experience. And I've already touched on some of these other components here. So I just wanted to share before wrapping up what my current plans are. We have a grant that we've submitted to NIH that we hope to be able to expand. Hopefully it'll get funded that we want to start tackling some of the issues here locally and expanding in clinical research. So, and while these are numbered, it's not necessarily having to be in any particular chronological order. But we're really looking to enhance the understanding of hEDS phenotypical variants. So essentially, like, how complex does this condition affect people? What is the symptom burden? And what is that progression as well over time? So how does it continue to advance or ideally improve? But on the symptoms, how does that look for various individuals? We want to engage individuals with hEDS as well as clinical providers to understand those critical gaps in care and knowledge. So we really want to know from providers and patients, what are the things that we should focus on? What do we need to tackle first and foremost? And then in an ideal world, where should we go with it? We want to evaluate diagnostic and standard of care experiences, including healthcare utilization and access to care. We're not even sure we're catching everybody appropriately. So we know the individuals who have access to care, but there are populations that we're questioning whether or not we're missing the diagnosis. Maybe they don't already have a diagnosis of hEDS, and why is that? We want to construct a comprehensive model of hEDS experiences and work on evaluating and refining current standards of care. And then also we want to increase awareness of hEDS prevalence, including through dissemination and educational training. So in a broad, high-level overview, those are some of the things we're working on as first initial steps in being able to move forward with clinical research in this area. And so to wrap up, I just want to say that your voice really does matter. For me personally, it matters so much. I think having all of you involved and encouraging others to be vulnerable, open up, to advocate is incredibly important. And I just want to say thank you to all of you for all you're doing. Thanks so much.